welcome to the Australian Dental Council Explainer podcast.
Yes, welcome.
And right up front, I need to state clearly that this content is purely educational, it's evidence-based, and it is definitely not a commercial endorsement for any product or publication.
Absolutely. We just want to make that clear before we dive in.
Right. So setting the stage for you today, whether you're an overseas-trained dentist, an ADC candidate, a dental student, or an Australian oral health therapist.
Our mission today is really to help you master the clinical reasoning you're going to need for your exams.
Exactly. We are doing a deep dive into Odell's clinical problem solving in dentistry.
A fantastic resource, by the way.
It really is. And specifically, we are unpacking case 10, which is simply titled A Lump on the Gingiva.
Yeah, and we are going to integrate all the critical oral medicine and pathology details you need to, navigate these clinical scenarios in the OSCE flawlessly.
Because these cases can be tricky, right? Like, why is this specific presentation such a staple in the exams?
Well, the reason this exact case is an exam favorite is that it forces you to synthesize everything at once.
Right.
You can't just memorize a list of conditions and hope for the best. You actually have to understand the pathophysiology behind what you're seeing.
I mean, they want to see your working memory in action.
Exactly. The examiners are evaluating how well you connect a patient's medical history to the visual presentation and then ultimately to the cellular mechanics happening under the microscope.
It's the whole picture. So let's get straight into that clinical presentation.
Okay, set the scene for us.
Right. So picture the scenario you're given in the exam. A 48-year-old man sits in your chair. He's complaining of a lump on his front left gum.
Okay.
It's completely painless, but he's bothered by it because it looks unsightly. And it bleeds really easily whenever he brushes his teeth or, eats anything hard.
It is a very, very common chief complaint. But in an exam, you have to proceed methodically.
Right. You can't just jump straight into the mouth.
No, you start with the medical history and the extraoral exam.
So the narrative tells us he is 48, slightly overweight, but generally healthy looking.
And crucially, when you palpate his neck, there are no palpable cervical lymph nodes.
Which is a huge relief, honestly.
It is. It starts to steer us away from some of the scarier differentials, but we'll get to that.
Yeah. So then we look at his medications. The history states he has hypertension, and it's currently controlled by taking 50 milligrams of atenolol daily.
Okay, file that away. What else?
Well, he tells you the lump has been growing slowly for about 4 months, and he has no other mucosal or skin lesions anywhere else on his body.
Right.
Now, I'm going to pause right here. Because as an ADC candidate reading this prompt, my brain immediately lights up at the word hypertension.
Oh, I see where you're going with this.
Right. Because we learn in pharmacology that blood pressure medications cause gingival hyperplasia.
We do learn that, yes.
So the patient is on hypertension meds. Boom. We are looking at medication-induced gingival overgrowth. Case closed. Let's move to the next station.
And you just stepped right into the trap the examiners laid out for you.
I figure. Wait, why is that a trap?
Let's look at the pharmacology of what you just suggested. It is absolutely true that certain antihypertensive drugs are famous for causing gingival overgrowth.
Like the calcium channel blockers.
Exactly. Drugs like nifedipine or amlodipine.
Right.
They do this by altering the calcium flux within gingival fibroblasts, which, decreases the cellular uptake of folic acid.
Oh, wow. Getting right down to the cellular level?
Well, you have to, because that creates a defect in collagenase production.
Meaning the body can't break down the collagen?
Precisely. The fibroblasts just keep pumping out collagen, but without collagenase, the body can't break it down. So you get this massive fibrotic overgrowth.
But, wait, atenolol doesn't do that.
No. Atenolol is a beta-1 selective blocker.
Oh.
Yeah, it does not interfere with the calcium channels in fibroblasts.
No.
So it's not classically associated with gingival hyperplasia.
So the examiner just puts atenolol in there as a distractor.
Exactly. They want to see if you actually know your drug classes, rather than just reacting reflexively to the word hypertension.
Wow, that is sneaky. But it makes perfect physiological sense.
It does. And honestly, even if we completely ignored the specific drug, the physical presentation itself doesn't match medication-induced overgrowth anyway.
Because it's localized.
Yes. Medication-induced overgrowth presents as a generalized condition.
Right, you'd see it everywhere.
You would see firm, fibrotic swelling across multiple papillae, usually throughout the anterior segments of the mouth.
But our patient just has this isolated 10 by 7 millimeter nodule.
Exactly. The fact that it is a single ulcerated bleeding lump strongly points toward a localized reactive or inflammatory process.
Not a systemic medication effect.
Right.
Okay, so let's visualize this localized lump based on Odell's description.
That picture.
We're looking at an irregular rounded nodule. It's about 10 by 7 millimeters. It appears to arise right from the gingival margin of the lateral incisor root.
And maybe the mesial dental papilla, yeah.
Yeah, right. And it's patchy red and pink, but it has this thin, gray, translucent sheen over it.
Okay, note that, Sheen.
The surface is ulcerated, and clinically, it is pedunculated.
Now, that word right there, pedunculated, gives us a huge clue about its mechanical environment.
Because it means it's on a stalk, right?
Exactly. A pedunculated lesion is attached by a narrow stalk rather than having a broad, flat, sessile base.
So it's mobile.
Very mobile. Mechanically, this means the mass just flops around. Every time the patient chews or his lip moves against it, that 10 by 7 millimeter mass is getting knocked about on its stalk.
Which perfectly explains the ulceration.
Yes, the constant mechanical trauma breaks down that delicate surface epithelium, creating an ulcer.
And what about that thin, gray, translucent sheen I mentioned?
That is a fibrinous exudate.
A fibrinous exudate. Okay, break that down for me.
So when the tissue ulcerates, plasma from the blood leaks out onto the surface.
Right.
The fibrinogen in that plasma polymerizes into fibrin. It creates this sticky, pale net across the raw, open surface.
And that net just traps things.
Yes, it traps dead inflammatory cells, bacteria, debris. That whole complex is what you are seeing clinically as a gray sheen.
That's fascinating. And then when we palpate it, and I know you must explicitly state you are palpating it in an OSCE setting, it feels fleshy and soft.
And what happens when you touch it?
The prompt says it bleeds immediately when touched with an instrument.
That immediate bleeding tells you this is a highly vascular lesion.
Just packed with blood vessels.
Right. The body has built a massive, disorganized network of blood vessels near the surface.
And because they are new, they're fragile.
Exactly. They're immature, they lack a proper smooth muscle layer, so they can't vasoconstrict effectively when they are bumped or probed. They just bleed.
Okay, so we have our clinical picture. It's a highly vascular, localized, reactive lump.
Now we have to formulate our differential diagnosis.
Right, and for the ADC exams, we need to be strict about this. We categorize our thoughts into likely, less likely, and unlikely.
Let's start with the most probable candidates, the usual suspects.
Okay, in the likely category, what are we looking at?
Well, based purely on the gingival site and the vascular inflammatory appearance, our top differential is a pyogenic granuloma.
Pyogenic granuloma, okay.
Closely followed by a fibrous epulis.
Right.
And I should also note, just as an exam tip, if our patient were a female of childbearing age, a pregnancy epulis would be at the very top of this list.
Those three seem to be the classic gingival reactive lesions. Are they fundamentally different conditions?
That's a great question. They actually exist on a continuum of the exact same hyperplastic inflammatory response.
Really? Just different stages?
Basically, yes. A pyogenic granuloma is the early, angry, highly vascular stage.
The red bleeding one.
Right. It is a mass of actively growing blood vessels trying to heal a localized irritation. Now, if it sits there long enough and the inflammation begins to naturally subside, fibroblasts move in.
And they lay down collagen.
Exactly. They lay down dense collagen. So that red bleeding mass slowly matures into a firm pink fibrous mass.
Which we then call a fibrous epulis.
You got it.
And what about the pregnancy epulis?
A pregnancy epulis is histologically identical to a pyogenic granuloma.
No difference under the microscope.
None. The only difference is the trigger. The exaggerated vascular response is being driven by elevated levels of estrogen and progesterone, which alters the local tissue dynamics in response to plaque.
Okay, so those are the most likely. What goes into the less likely category for this 48-year-old man?
A peripheral giant cell granuloma is a strong secondary consideration here.
Because it looks similar?
Clinically, it looks very similar, though sometimes it's slightly more purple or maroon in color.
But it's fundamentally different.
Yes. Unlike the pyogenic granuloma, which arises from superficial connective tissue, the giant cell granuloma originates deeper. It comes from the periodontal ligament or the periosteum.
Okay, good to know. Any other less likely candidates?
Another one is a sinus papilla, which is commonly called a purulus.
Oh, a purulus. That is essentially the exit wound of a draining sinus tract, right?
Correct.
Usually tracing back to a dead tooth.
Yeah, it's a localized accumulation of granulation tissue right at the opening of a sinus tract, draining pus from either a necrotic pulp or a really deep periodontal abscess.
Got it. And finally, we have to list the unlikely possibilities.
The rare, dangerous conditions we always have to keep in the back of our minds.
The masterminds on our suspect board.
Right. In the unlikely category, you would place benign tumors like papillomas or hamartomas, and, crucially, malignant neoplasms.
Like leukemia.
Leukemia can definitely present with gingival swelling, though honestly it is usually generalized and very boggy due to leukemic cells infiltrating the gingiva everywhere.
Not just one localized 10-millimeter lump.
Usually not. You could also see metastatic deposits, or, if the patient's immune status was compromised, Kaposi sarcoma is a vascular malignancy that looks very much like a bleeding red lump.
Okay, so we have our differential diagnosis structured perfectly for the examiner. Now we move into the investigation phase to rule things out.
And in an exam setting, remember, you can't just order every test in the book.
Right, you can't just tick every box.
No, you have to justify your clinical logic.
So Odell's text dictates we start with a periodontal examination.
The goal here is to find the local irritant causing this exaggerated tissue response. We need to assess the pocketing around the teeth.
Okay, so the findings for this patient show generalized chronic adult periodontitis with 3 to 4 millimeters of clinical attachment loss.
Okay, standard for a 48-year-old with perio issues.
But right next to our lesion, right on the lateral incisor, there is a 5-millimeter probing depth.
Ah.
So does he have localized severe periodontitis right where the lump is?
Not necessarily, and this is a very important distinction. The text explicitly describes this 5-millimeter measurement as a false pocket.
A false pocket. Let's clarify that technically.
True periodontal attachment loss means the junctional epithelium has actually detached from the tooth and migrated down the root toward the apex.
Right, true bone loss and attachment loss.
But a false pocket means the attachment level on the root hasn't moved at all. Instead, the swollen, hyperplastic gingival tissue has expanded upward over the crown of the tooth.
Oh, I see. So when you slide your periodontal probe in...
It goes 5 millimeters deep. Simply because the tissue wall is artificially high, it's swollen upward.
That makes total sense.
Yeah.
But the depth still matters, right?
Absolutely. Because deep inside that 5-millimeter false pocket, the examination reveals subgingival calculus.
And there is the culprit.
Exactly. That subgingival calculus is essentially a biological splinter.
A biological splinter. I like that analogy.
It's a calcified matrix, completely covered in living bacterial biofilm, and it is constantly scraping against the inner lining of the gingival sulcus.
So the immune system is just going crazy.
It's throwing everything it has at this splinter, and that is what triggers the massive vascular overgrowth we see clinically.
Wow. Okay, so we found the local irritant. Next up is vitality testing.
Vitality testing is crucial here.
We use an electric pulp tester, an EPT, on the lateral incisor and the adjacent canine.
Right.
The EPT sends a small electrical current through the enamel to stimulate the A-delta nerve fibers inside the pulp, and the patient feels a tingling sensation.
Which confirms what?
It confirms both teeth are vital.
Exactly. And this specific test allows us to cross a major diagnosis off our list.
The peripheral.
Yes. But let's look at this from a busy clinic perspective for a second.
Okay. I've found a deep pocket. I found a lump. I know dentists love taking x-rays to see what is happening in the bone.
We do love our radiographs.
Right. So to be incredibly thorough, and just to make sure we don't miss anything, shouldn't we just take a periapical radiograph of that incisor?
Well, in a real-world clinic, a clinician might take one out of habit.
Yeah, just to be safe.
But in an evidence-based exam setting, ordering that radiograph is considered a logic failure.
Wait, really? You'd lose points.
You will absolutely be penalized for exposing the patient to unnecessary radiation.
Oh, wow. Why is it unnecessary?
Follow the diagnostic tree. We just proved with the EPT that the pulp inside the incisor is vital.
Right.
A peripheral, which was on our less likely list, is caused by a necrotic pulp leaking infection out of the apex of the root.
Oh, I see. If the pulp is vital, there's no necrotic tissue.
Exactly. No necrotic tissue, no periapical abscess, and therefore absolutely no draining sinus tract.
So periapical radiograph would just be looking for something we already know isn't there.
Precisely. Because we logically ruled out a periapical infection, taking a radiograph specifically to look for periapical pathology is not indicated.
You just have to trust the results of the clinical tests you just performed.
You do. The examiners want to see that you trust your own diagnostic logic.
That makes complete sense. Okay, so we ruled out the dead tooth. We proved it is not a systemic medication issue from the anatinol.
Right.
We found the subgingival calculus. Everything points to a reactive lesion like a pyogenic granuloma.
So now we move to the treatment strategy.
Yes, let's discuss management, and specifically the protocols for biopsy.
The definitive management plan requires multiple steps to ensure both resolution and to prevent it from coming back.
Okay, step 1.
First, an excision biopsy to remove the lump and get a definitive histopathological diagnosis.
Step 2.
Second, scaling and root planing to entirely remove that subgingival calculus. We have to remove the splinter.
Right. Step 3.
Third, comprehensive treatment for his generalized periodontitis across the rest of his mouth.
And finally,
Addressing the root of that lateral incisor, either by restoring it or extracting it if it turns out to be compromised.
okay, but regarding the surgical approach itself, Odell's text outlines a really interesting conservative option.
It does.
Instead of just picking up the scalpel immediately and cutting it off, is there a benefit to staging the treatment?
Staging the treatment is brilliant, and it demonstrates a really deep understanding of tissue dynamics to the examiner.
How so?
Well, if you go in first and purely focus on removing the subgingival calculus and improving the patient's plaque control, you are actively removing the stimulus.
Taking the splinter out before you treat the swelling.
Exactly. Without that bacterial splinter triggering the immune system, the vascular storm retreats.
The blood vessels literally shrink.
They do, because they don't need to deliver an army of inflammatory cells to the area anymore. The war is over.
Wow.
So the softer, highly vascular pyogenic granulomas will undergo partial resolution. The mass physically shrinks.
And the clinical advantage for us as the dentist is huge, right?
It's immense. Think about it. A 10 by 7 millimeter highly inflamed pyogenic granuloma is going to bleed profusely the second your scalpel touches it.
Just totally obscuring your visual field.
It's a mess. But if you let it calm down and shrink for a few weeks, you are left with a smaller, much more fibrotic mass.
Which is easier to cut.
Significantly easier to excise, and it bleeds far, far less.
That is a great clinical tip. Now, when we do finally perform that excision biopsy, the source text highlights a critical protocol for handling the tissue.
Yes. Tissue handling is a huge OSCE trap.
Because a small, slippery 10-millimeter lump is hard to hold with forceps.
Very hard.
And if you aren't careful, your dental assistant's high-volume suction can easily pull it right out of the surgical site and into the vacuum lines.
And then your biopsy is gone forever.
Exactly. So to prevent this, surgeons often pass a suture through the lesion beforehand, right? Just to act as a tether.
It's a great surgical technique. The tether gives you control, but it creates a risk during the tissue handling phase afterwards.
Odell's protocol clearly states, to avoid distortion or crushing of the specimen, do not remove that suture once the lesion is excised.
Never remove it.
Why does removing a single piece of thread matter so much to the pathologist?
Because think about how you have to remove it. Removing the thread usually requires you to grab the delicate tissue with surgical forceps to hold it still while you pull the thread.
Oh, and the forceps damage it.
Yes. When you squeeze a small piece of vascular tissue with metal forceps, you cause what's known as crush artifact.
Crush artifact.
You are physically bursting the cell membranes. You're collapsing the delicate endothelial lining of all those little blood vessels.
So you're destroying the evidence.
Exactly. When the pathologist puts that crushed tissue under the microscope, the cellular architecture is ruined. It makes it incredibly difficult, sometimes impossible, for them to give you an accurate diagnosis.
So the rule is simple.
If you tied a suture to it, leave it in. Just cut the thread a centimeter or so away from the tissue and drop the whole thing, suture and all, directly into the formalin pot.
Okay, so we drop the uncrushed specimen into the formalin and it goes off to the lab.
Right.
Let's look at this from the pathologist's perspective now, because histological interpretation is a very common component in the pathology stations of the ADC exam.
It is. They will give you the slide and ask you what you see.
So when the pathologist slices the tissue and stains it, they look at the surface first.
Always start at the surface.
And just as we saw clinically, the microscopic surface is ulcerated. The normal stratified squamous epithelium is completely missing.
Right.
Instead, the surface is covered by a thick slew of fibrin, and embedded within that fiber net are thousands of neutrophils.
Which perfectly confirms the active inflammation.
Because neutrophils are the first responders.
Exactly. They're the immune system's first responders to acute tissue injury and bacterial invasion.
Okay, so moving deeper into the tissue, below that ulcer, we see the defining characteristic of this lesion.
What do you see?
You observe pale-stained edematous tissue.
Meaning it is swollen with fluid.
Right. And throughout this fluid-filled tissue, there is a massive proliferation of endothelial cells forming numerous small blood vessels.
Lots and lots of little blood vessels.
And Odell specifically notes these blood vessels are arranged in a, quote, distinct radiating pattern.
Yes.
Why do they radiate? What does that mean?
They are radiating outward, pointing directly toward the ulcerated surface.
Flowing towards the breach.
Exactly. This is active angiogenesis. The deeper blood supply is rapidly branching and growing new vascular pathways upward.
To deliver more troops.
To deliver more neutrophils and immune mediators right to the breach in the tissue surface.
That is so cool to visualize. And deeper still, you will see clusters of chronic inflammatory cells and prominent bundles of collagen.
So based on this microscopic architecture, an ulcerated nodule of maturing granulation in fibrous tissue, the definitive diagnosis of pyogenic granuloma is confirmed.
Boom. Nailed it.
But, to broaden the scope for candidates, examiners love to push the boundaries of a case with follow-up questions.
Oh, definitely. Like, what if the pathologist's report comes back and notes that there's bone formation found deep inside that pyogenic granuloma tissue?
That is a very classic exam pivot.
Okay, so how do we handle that?
If calcification or bone is found within the cellular matrix of the lesion, the terminology changes slightly. We refer to these as mineralizing epulides.
Mineralizing epulides, or in many texts, peripheral ossifying fibromas, right?
Yes, those terms are often used interchangeably in this context.
Now, if I'm the patient and you tell me my gum lump has literal bone growing inside of it, I am going to panic. Does the presence of bone mean the lesion is more aggressive? Or that it has a higher chance of coming back after we cut it out?
It's a very logical assumption to make. But the source explicitly notes there is no good evidence to support the belief that bone formation equals a higher recurrence rate.
Wait, really? No higher recurrence?
None. The presence of bone simply tells us about the lesion's origin story.
What do you mean by origin story?
It indicates that the inflammatory proliferation likely started deep enough to involve the periosteum.
The periosteum being the connective tissue layer covering the jawbone itself.
Exactly. And the periosteum contains cells with osteogenic potential.
Cells that can make bone.
Right. So when those cells get pulled up into the inflammatory mix, they just do what they do. They sometimes lay down small spicules of bone.
So it's just an innocent bystander effect, basically.
Yes. It does not make the lesion more dangerous or malignant.
But speaking of malignancies, we always have to be vigilant. Even though this case was a straightforward, benign, reactive lesion, Odell's text strongly emphasizes why we never, ever throw tissue away without testing it.
You must biopsy everything.
No.
Because severe pathology can perfectly masquerade as a common dental problem.
Like what?
Well, extraosseous manifestations, meaning soft tissue growths outside the bone of conditions like Langerhans cell histiocytosis or squamous cell carcinoma, can occur right on the gingival margin.
Wow. And to the naked eye.
To the naked eye, a squamous cell carcinoma might look exactly like a stubborn, localized gingival swelling.
Or an ulcerated pyogenic granuloma.
Exactly. The biopsy is not just a procedural formality for your notes. It is the only way to definitively rule out a life-threatening mimic.
So to trace the clinical logic of this entire deep dive, we started with a localized bleeding lump.
We did.
We navigated the pharmacological distractor of the beta blocker, atenolol. We built a differential diagnosis anchored by the statistical probability of reactive lesions on the gingiva.
Methodically ruling things out.
We used the electric pulp test to scientifically eliminate a draining sinus tract, which spared the patient from an unnecessary radiograph.
And saved you marks on the OSCE.
Exactly. We understood the physiological benefit of removing the calculus splinter first to shrink the vascular overgrowth. We preserved the cellular architecture for the pathologist by not crushing the biopsy suture.
Crucial step.
And finally, we connected the clinical ulceration to the microscopic reality of angiogenesis and neutrophil infiltration to confirm a pyogenic granuloma.
It perfectly illustrates how practicing evidence-based dentistry requires you to seamlessly shift between the roles of a diagnostician, a surgeon, and a pathologist.
It really does.
Yeah.
But before we wrap up, there is one final, larger concept to think about from this case.
Oh, what's that?
Well, we found subgingival calculus in that false pocket, right?
Right.
In the rest of this patient's mouth, that exact same calculus at the exact same bacterial biofilm is causing generalized chronic periodontitis.
True.
It is triggering his immune system to release cytokines that activate osteoclasts, literally dissolving the bone away from his teeth.
It's a destructive process.
Yet in this one specific localized spot on the lateral incisor, that exact same irritant triggered the tissue to do the exact opposite.
I see what you're saying.
Instead of breaking down and receding, the tissue hit the hyperproliferate button. It built a massive fleshy vascular network of granulation tissue.
It grew instead of shrinking.
Right. So what dictates that choice? Why does the body look at the same bacterial insult and choose destruction in 1 millimeter tissue, but explosive cellular proliferation in the next?
That is the ultimate question. Understanding that cellular tipping point, the delicate balance of cytokines and growth factors, is where the true mastery of oral pathology lies.
Something to mull over until next time. For more dental examination prep tips and clinical deep dives, please subscribe and share this episode.